Shall we start?
यस मैम लाइव कर दूं मैं
लाइव कर दो और फिर मुझे बस बोल दो कब स्टार्ट करना।
जी मैम वी आर लाइव
Assalamu alaikum and a very good afternoon to everyone who has joined us today for yet another session on the DCPE-CME Hour. Few disclosures and house rule to follow. This CME Hour today is being supported by Abbott Laboratories Pakistan. Please make sure to send in your questions at dcpe.aku@gmail.com. I'll repeat this again. Your questions can be emailed to dcpe@dcpe.aku@gmail.com. With that, today's topic is exploring fever management in children, and our guest speaker today is Dr. Ali Faisal Salim. Dr. Ali Faisal Salim is an associate professor and vice chair at the Department of Pediatrics and Child Health here at Afan University in Karachi. He has a vast experience in pediatric infectious diseases, vaccines, immunity, and childhood nutrition, and is involved in research and clinical trials which are focused on polio eradication in Pakistan. And this eventually helps in improving vaccine outcomes in children. Dr. Salim also actively advocates for vaccines and school health education and is the chair of the Immunization Committee and director of the Infectious Diseases Research Laboratory here at AKU. Dr. Salim has more than 70 indexed and 20 non-indexed publications in well-reputed journals, and he has more than 20 extramural research grants to his credit. And with this, thank you so much, Dr. Ali, for doing this for us today. And I give you this virtual floor to continue with your topic.
Thank you, Natasha. Bismillahirrahmanirrahim, and thank you, DCPE team, for inviting me to give a small talk on exploring fever management in children. And I'm sure at the end of this talk, we will be able to understand the basic understanding of fever in children, how to diagnose it, and what are the possible and potential management plans one can think of. As Natasha has mentioned about the housekeeping rules, I appreciate if you just keep writing the questions for me, and I try to make sure that I try to answer as much as I can by the end of session and the time which is, of course, available. Uh, okay, so let's ahead with the disclosure statement that I have. Although this program is supported by Abbott Laboratories, that what Natasha has said, but I have no financial relationship or any proprietary entities producing, marketing, reselling, and distributing healthcare goods or service consumes or use on patient in the past 24 months. All right. So what we discussed today is what is fever, what starts it, what to see and look at, how to explore it, and management plans and do's and don'ts of fever. The learning objective is to understand the causes and origins of febrile illness in children, to recognize the clinical symptoms and potential indicators of poor prognosis in febrile children, to learn about the appropriate clinical tests and how to interpret the results for a child with a fever, to understand the management, discharge, and follow-up plans for a child with a fever. And lastly but not least, what are the referral process in educating the family of a febrile child? And last is actually we're going to work together and explore more about what we can do for our patients when they wanted to go home. So this is a small question for you, and I'm sure the people who are online can take this question and just write the question's answer. And by the end of the session, we will be able to understand what is really the fever rate. So what is the fever in a child? Um, when a baby is warm to touch, or when the head and body are the warm, it is more than 98.6 degree Fahrenheit, or it is 100.3 degree Fahrenheit or more, or I know, but I will not tell you. And I ask you to please write any of the potential leaf which is fine and you think this is fine or appropriate here. The second question is, what is the most common causes of fever in newborns? And people can consider viral, bacterial, fungal, overacting, or mera jawab meri marzi, right? So what is best you think is the best answer? You just write here on your paper, and then we can discuss further when we end the session. So for me, the fever is the most common complaint, and whenever I see a patient in my clinic, out of 100 patients, 95 or more come with this fever. Mostly it is arbitrary. Arbitrary means people have their own understanding about the fever, right? Sometimes it's just warm to touch, head warm, hands warm, body warm. Thermometer doesn't say, but I feel the child is fever. So different kind of things come out when the mom comes to your clinic with this child who has fever. We need to understand that fever, it's a cause and it can be a manifestation of the symptoms that can happen, right? So suppose, so this manifestation means that there could be a bacterial infection or viral infection and the fever can come. They may be just overlapping and then can lead to fever. Or this is just fever that leads to any other symptoms like febrile, seizure, and others. So it can be in anything. It can be a cause and it can be a manifestation. What is its definition? And you can see majority of time the people come to us with this hand touch on the head. This is a photo taken from internet resource. So for the pediatric, it's 100.3 or more is fever. And why it is 100.3 or more is a fever? The reason behind is the metabolism of the child is high, the heart rate is high, and the metabolic rate, or that's called anabolism and catabolism, really high in a growing child. Hence, 100 is never been considered as fever for the child. Even not 100.1 or 100.2, but something which is 100.3 or 37.99 is considered as fever in a child. Hence, we ask the parents to take any of the thermometer to take this appropriate checking of the fever. Uh, People used to use their palm or other surfaces to check the fever method, and if they're so sure about it that this is fever, but I would discourage that we use this methodology for us for a I would say for a cooling purposes or for the safety for the like good behavior purpose, but thermometer is the best way to check. Which thermometer is the best? And the answer is in your own hand, right? You just decide what is the best for you. In COVID times, we realized that digital thermometers are no more needed, and we use this scanner kind of thermometer checking in the airport setting, and you can see all those thermometers are attached as an MRI machine, and they're just checking randomly across the people on the airports what are their body temperature is. But usually we can use either the digital thermometer. You can see this screen here on my laser pointer. This shows a kind of temperature reading, and this is the mercury thermometer. The problem with the mercury thermometer is, again, it's really required to see this yellow line and the mercury level in that yellow line that can indicate the temperature setting. But digital thermometer can also attach with a noise. So anytime they're ready to check, the noise can pop up and you can check the thermometer that, okay, this is what is the current reading of that. We can also discuss about this addition and subtraction rule. And majority of time, the people come to our clinic, they always talk about this thing. So is there any significant difference between digital and glass mercury thermometer? And you can see this is a linear curve and R2 analysis that shows the correlation between the thermometer reading. So on the right side, on this lower side, this is a digital thermometer, and this is this mercury thermometer. And you can see the lines of this temperature recording for more than 96 or 98 observations clearly indicate there's not much difference between this thing, and there's a very good high correlation between these two findings. So either you can get any of the digital or glass thermometer, mercury thermometer. the temperature remains the same. So you can clearly see this mean and standard deviation taken by both mercury and diesel thermometer. There's no much difference. 37.3, 37.43 with the standard deviation is the same. Just a 0.2 degree difference that can happen. But again, it is 0.2, 0.98 and 0.2. It's not much for differentiate that this is better or this is other. So for me, any of the thermometer can be taken, and it's a very good study was published by the nursing lead in one of the hospital published in 2016. So while checking the thermometer with temperature with the thermometer, what is the concept of addition or subtraction, and which one is correct? And I want you to please identify which is the right answer here. So the answer could be yes, we had to add +1 while checking the head temperature recording, or we have to subtract -1 while checking the head temperature recording, or we have to subtract -1 while checking the axillary temperature recording, or add +1 while checking the axillary temperature recording, or no, it is not necessary. So whatever you think is correct, just mention in your on your paper, and then we can discuss later. So my answer is, do we really need this? And the answer is, of course, not recommended. These are old thoughts and have no scientific data or rationale to produce anything. You can just use Google, write the Google thing, and you can see a lot of people going to talk about this thing, subtraction, addition, but they are their blogs. They are their own understanding, but this is not scientifically proven that we have to add or subtract, except the rectal thermometer, which is not using anymore to check the core temperature of the body compared to the other. But rest of the time, it's just not recommended and not needed. Fever, and what does this mean? Remember, like this is important that we are living in an era where we have our pathogens are actually resistant against a lot of antibiotics, and not only this, but also our antibiotic prescription rate at the primary care level is more than 90%. That means that out of 100 prescription, 90 prescription has some kind of antibiotic mentioned in that. And I read somewhere else that fever is not a sign of antibiotic deficiency in a child or adult or adolescent. Hence, we really need to understand if the child has a fever, what can be or what could be a cause of this fever or this febrile activity or febrile temperature of this child. For me, my understanding about there are two kind of phenomena. One is sneezing. Sneezing is a body protective measure. So people think that sneezing can be a bad thing, or this could relate this sneezing to a religious activity. For me, sneezing is a body protective mechanism where the hair follicles identify an allergen and try to pull it out, and they produce certain kind of response where a blow of nose or a blow of this air can take out this antigen away from the nose. So it's a body protective measure. And same with the fever. Fever is a body protective measure. When your body core temperature has risen up, the body start producing different kind of phenomena where cytokines and interleukin release happen, and they increase the body temperature to make sure that they can burn the a pathogen inside the body. And usually it's an autonomic control system, so it's not in my hand, it's not in your hands. So the body know what to do at this situation, and that's how the body was trained, and that's how the body is trained for any of the child. But we can certainly identify the difference between infectious diseases versus non-infectious diseases, and how to go about it. For me, I think the simple reason here is each one of us to understand is uh, if your child is having a fever and having a fever medicine, he's happy up and about, it means that probably it is infectious, it's a non-infectious or infectious etiology. So how you differentiate between these things, and I'm sure each one of you understand that in infectious etiology is always a pathogen. However, in non-infectious etiology, it's just not a pathogen, it's something else. And that pathogen can be viral or parasite or fungus. However, in non-infectious etiology, there are multiple reasons, and those multiple reasons can be dictate has it either dehydration, and the time which we are going through right now, extreme heat temperature in Karachi and other part of the Pakistan, a lot of heat stroke happen, and you can see a lot of heat stroke sensitive centers available across the roads, both sides. There are other diseases like diabetic ketoacidosis or metabolic acidosis, malignancies, strenuous exercise. A lot of allergies can give you a lot of fever. But again, importantly, is every second or third week, I have a child in my clinic with persistent fever and a lot of antibiotics. and majority of time it's just a drug fever that happened to those children. And once I off those children from the drug, I clearly identify that the fever has gone down. So like this is a very real phenomena, and one has to understand that switching the antibiotics not work. We need to identify what is causing to fever in this child. Yeah, so infectious disease is one of the most common symptom and signs of any infection. The fever is one of the most common, and every child, more than 90%, these febrile or episodes in children are viral. So and then again, and why these viral things happen? So remember that a lot of virus do not give you long-term immunity; they just give you short-term immunity. A lot of respiratory viruses, like what is going on in winter seasons, and in summer, the diarrheal season. A lot of viruses can give you respiratory illness and diarrheal illness, just because your body exposed to certain virus and do not produce a long-term immunity. Hence, their antibodies are not there to protect them for certain types of recurrent infections. And this is one of the most common phenomena in our clinical setting, when a child come to us with a recurrent cough and flu or recurrent diarrhea, and majority of time we just need to just counsel them on the basis of your experience, clinical findings, and history and examination. This is just a simple viral infection and persistent viral infection, or a different kind of viruses going on with this child. When majority of time this does not require any further investigation, but just takes a look good and a closer follow-up. We also need to understand that majority of time the virus infection strains do not give you immunity. Suppose the dengue has the 4 different kind of strains. So anytime you have affected by one kind of dengue viral strain, the you do not get the immunity for the other 3 strain. Same for the malaria. So malaria vivax, if you have it, do not give you immunity against malaria, ovale, and falciparum. Um, and lastly but not least, these infectious viruses are actually highly transmissible, and even even um, even if you are removed to your body these kind of viruses, your body is vulnerable for the other kind of virus, which is again in the community. Lastly but not least, we have vaccines that protect us from these infections. But try to understand, we have very limited vaccines available for very limited kind of viral infectious etiology. However, we are lucky enough to have a EPI viral infectious vaccine that protect us from the lot of EPI 12 preventable antigens diseases in the EPI. But these are the most common preventable. But lately there are need of other viruses, vaccines like RSV, parainfluenza, human metapneumovirus, and other that can help us further to protect our children from other infectious diseases. How you differentiate between viral and bacterial infection? So in the bacterial infected child look sick looking. They have plenty of febrile episodes. Their appetite has not come back. Their response to antifebrile medicines are there, but they are not very much. However, in the viral infection, they remain active, they remain playful, the appetite returns once the fever has gone down. But in both the situation, you have to understand there is a management. The management is, you have to understand there is a very good uh, mm, fever medicines available. So there are 3 medicines I have mentioned here: paracetamol, mefenamic acid, and ibuprofen. So try to understand each of the drug has its own positive and negative thing. So, but the best is the paracetamol. Paracetamol is a very good fever medicine, and in majority of the setting, this is the best drug that has to be given, except if you are allergic to paracetamol, and 2% of the population is actually is allergic to paracetamol, and you have to identify the alternative, and the alternative are mentioned here as well. The dose is 15 milligram per kilogram per dose, Q6 hourly, and you have to understand there's a maximum daily dose as well. And there's a 72 hours, and in the later slide we're going to discuss about the 72 hours rules as well. I'm just checking my time, so just 20 minutes gone. So you also need to understand that you have to give good tap water showers. It has to be lukewarm water in the winters. Uh, I usually ask people not to do sponging, because sponging will not help you. Just taking a good shower, 4 to 5 minutes under the shower, will help your child temperature go down as soon as possible. And no alcohol swab, because we saw a lot of bad axillary infection or axillary burns after using this alcohol swab or a sprit swab, which is using in the community. It's a bad practice and one should just avoid it. So just a couple of slides on the danger signs. That's really important, that a racing heart is a bad sign. It's because a racing heart is a failing heart in pediatric. So anytime you have a child who has persistent tachycardia despite giving paracetamol, it means that you are in a bad situation, and you have to just identify how to send this child to a secondary or a tertiary care facility as soon as possible. That's for me, GC, before the GCS has gone down, the heart rate tells you that what is going to happen to your patient. Secondly is low GCS, and again, drowsiness and seizure can happen to any febrile child. It can be a sign of bacterial infection, meningitis, viral infection, encephalitis, or it could be just a febrile illness that leading to drowsiness and seizure episode. And hypoglycemia is one of the important factors as well. Uh, Urine output is also one important danger sign. Low urine output in a febrile child means that's end organ damage happen. All these three signs you see, these are end organ damage sign. They usually do not happen as in the early phase of the diseases, but if you miss the identify the cause, that they rapidly happen to our younger ones. The other danger sign are increasing abdominal girth and ascites, particularly it tells us that there is a failing liver. It usually happens in viral etiologies and other viral infections that affect the body and the liver as well. Bone marrow suppression in the form of thrombocytopenia is another danger sign, and one has to understand, identify, and just transfer the patient as soon as possible. Lastly but not least is one of the most protective, I would say, layer we have in our body is the skin that protect us from everything outside and inside. And if the skin is denuded, it means that that there is exposure to other pathogens that can invade through the skin and go to the body and give you more sepsis and infection. What to do when you feel a bad disease, right? And all those bad disease signs I have mentioned you. So the bad disease, the must is that there are three things which you need to understand. It's an end organ damage with or without failure. And if you have one or any of the danger sign along with abnormal vital signs, and when talk about vital signs, we not talk about heart rate, saturation, pulse rate, blood pressure, and peripheral capillary, I would say, capillary refills. So these are the five things you need to understand, and also the GCS. And anytime you have this kind of this bad disease sign, you have to do few things. You have to do investigate for rheological, hematological, and also understand that you have to do more serum markers if there's a needed. Um, so if you have a young child with first febrile seizure coming to your clinic or outpatient setting or inpatient setting, you do have to do a triple tab. You have to do a CSF, blood, and urine culture. You have a complex febrile seizure in an infant, right? So suppose the infant has a febrile times in the past, but this is a complex febrile. It means that seizures happen for a certain amount of time, and this happen multiple times in a day. It means that there's something really bad going on, and you need to investigate their child. An excessively crying infant, again, it is a bad sign, and then you have to understand, okay, we have to do a triple tap, we have to assess a blood and urine. These are the must things, and one have to consider that this is must counseling. You have to identify that if you missed any of these things, the chances, and if the child has a meningitis, the chances of complexity and complications are more in these individuals. So let's talk about acute bacterial meningitis. And each one of you knew it's a inflammation of meninges. Sometimes we know our pathogens, sometimes we do not. Majority of time is community acquired, and it's usually vaccine preventable pathogen that actually cross our blood-brain barrier and get us in a stage where we have this bad infection. Um, Sometimes also the health facility acquired, and we used to see these kind of infection when you have a shunt placed, and then shunt got another kind of pathogen, bacterial meningitis from the hospital and others. And also, where are you residing right now? That's also important, because the microbiology comes from uh, it's important to understand the microbiology, because the resistance pattern come, or the drug sensitive pattern come from the local area. or there's an outbreak happen for of any pathogen in the community setting, and then you have the patient who has signs of meningitis come to you. And in the neonate, it's usually maternal flora, which is called early onset neonatal sepsis. If this is happen 72 hours, but anytime this is more than 72 hours, usually community acquired, and not the maternal one. In our setting, the gram negatives are actually a threat. Gram negative means Sclerotia coli, Klebsiella, and Mingoni, because they're coming from the maternal flora. In a hospital setting, if your child been too, there are a lot of other pathogens like Acinetobacter and Klebsiella pneumoniae again. Uh, Recently, we have a international or national outbreaks of carbapenem-resistant Enterobacteriaceae across the hospitals in Pakistan, and that's just because of these pathogens develop certain kind of immunity, certain kind of resistance against our conventional antibiotic. However, in infant is usually community acquired and mainly Streptococcus pneumoniae, hemophilus influenza, and these are the individuals who are actually not vaccinated or partially vaccinated or somehow escape the vaccine, or the body is do not able to produce the amount of immunity that is supposed to happen. um, the other most common is Mycobacterium tuberculosis. Remember this. This is one of the potential cause of meningitis in children who are just comatose, come to you with a persistent seizure episode. Lastly, but not least, early identification is really important because the outcome in of these pathogen in these younger children is actually bad. They have long-term neurocognition and neurodevelopmental severity, and they really need to be supported if they develop these long-term complications. These are the common signs in an adolescent or young child, like fever, vomiting, severe headache, stiff neck, photophobia, rash, seizure, confused delirium, and others. There are certain challenges in terms of diagnosis of meningitis, and I will talk about one of the important challenge here. I just mentioned four, like seizure, availability to microbiology in any other centers, associated symptoms, and we'll need CT scan compared to lumbar puncture, particularly if you have a persistent seizure or a unilateral seizure. However, but lastly but not least, I really want to talk about this lumbar puncture and why it is important for each one of us to understand that this is one of the most important tests one can think of and has to do, because that's the only gold standard we have. CT scan is not a replacement, MRI is not a replacement of the lumbar puncture, because in the lumbar puncture, you just know to have CSF, DR, and culture, but also you have this understanding of the resistance of the pathogen. You can also understand how long you have to give antibiotics. They are concerned about skill and who will do, physician availability, residence availability. In your secondary care hospital, you don't have enough staff to help you out. In a private hospital or private setting, you don't have enough medical officer who's trained to do the lumbar puncture in pediatric population. And we're always concerned about field procedure, not only field procedure because of not giving enough sedation, but also because we're not good enough to understand the space. And again, once we're not trained for something, we failed almost every other attempt. But sometimes there is anatomical abnormality like spine problem or traumatic injury that can lead to failed procedure. Then again, availability to procedure room, because I remember in my medical schooling in Civil Hospital Karachi, the procedure is done on the bedside and not on the procedure room. But again, most of majority of the hospital system and network develop this procedure room to make sure that safety and ethics has maintained for their patients. Again, we always concerned about PTNI and bleeding disorder, but remember that platelet is the only thing that you have to do is more than 50 platelets good enough to do the lumbar puncture. PTNI is not recommended, not needed, but that seems like that is going on for last so many years that people think that's the only mandatory test. And also people really want to do a CT scan before lumbar puncture, but again, there are certain ways where lumbar puncture is indicated. A CT scan is indicated before lumbar puncture and not beyond it. Lastly, but not least, we have this kind of phenomena of parental refusal, where the family think that this is not safe to do a lumbar puncture of multiple reasons, and few of the reasons are actually that some bad thing happened to the child. They cannot walk, they cannot stand, they have this kind of persistent immobility, there are certain myths, and all those myths can be easily answered by your own knowledge and understanding about the disease. Second most common is urinary tract infection, and it is one of the second most commonly diagnosed in the emergency setting and OPD setting. Usually, the patient present with high grade fever, excessive crying, color of the urine is changed, frequency and urgency has decreased, and the smell is also something that you also need to understand that it can be really bad. However, the most important, most common test that can happen in any of the setting is a urine diagnostics test. But there are other tests as well, like urine direct report and urine culture. So anytime you have a consideration for a urinary tract infection, make sure that you not only the urine DR, but also send the urine DR and culture. But anytime you send a urine DR or urine diagnostic, you have to understand there are two kind of things you actually have to see. One is leukocyte esterase, and second is nitrite. Third is of course the BBC count as well. So anytime you have a high you have a positive leukocyte esterase but negative nitrite, it is a probable UTI but not a definitive UTI. And if you have a nitrite positive and leukoesterase negative, then again you have a suspected UTI and not a potential or not a confirmed UTI. For a confirmed UTI on a urine DR, you need to have both positive and availability of WBC count. And then of course you have to send a sample for a urine culture. But then again, in majority of setting, what we do is we do a urine bag sample, and I would certainly discourage it. That should not happen and should not do this type of procedure while you're doing a urine sampling. The reason behind it, the urine bag walls inside and outside can be contaminated from the stool samples and then give you false positive result for urine infection. So it is not recommended, and majority of time when a patient come to me with a urine culture report with a positive urine culture or urine DR test using a bag sample, I usually do not treat, and I clearly refuse to treat these patients because this is not needed and indicated until unless there is a clear-cut indications for in other tests like WBC count in the serum and also the high-grade fever, persistent high-grade fever. So for me, the bag specimen are not needed. A clean void sample is the best thing. In a younger children, either you do a in and out sample that's called catheterization. Nobody does the suprapubic aspiration anymore, but the best is like you do an in and out test, and that's the easiest way and perform. And majority of time when you talk to your parents and patient's parent, they will be happy to support your concern and support to get this child in and out samples. How long the sample can stay in the room temperature, the urine culture bottle. That's also important that majority of time that's happened that the urine culture bottle or urine DR test remain on the counter or urine receptionist counter for longer period of time. So the most important thing is that it has to sample has to be collected and sent to laboratory as soon as possible within 30 minutes. If not, then the temperature recording has to maintain the temperature, and then the urine sample has to be stored at 2 to 8 degrees Celsius. Otherwise, the container pathogens will grow inside the urine culture and then urine and then they contaminate the real picture. If you have the lastly but not least, I would like to talk about enteric fever, and a persistent high grade fever for more than 3 days. You always consider is as enteric fever, and this is one of the most common diagnoses we have in our outpatient setting, particularly when our children are drinking not safe water and hygiene outside and inside are not maintained. We have a fly season, we have a post-monsoon season, and we have a very dry season right now. And then all these seasons end up with salmonella to grow in these community setting. And also, we also need to understand that if our child is not responding to conventional paracetamol and conventional medicines, then we have a strong understanding or strong suspicion of this enteric fever. And anytime you have a consideration of enteric fever, make sure that you do two tests. And these are the two most important tests. One is complete blood count and second is blood culture. Do not do any serological markers like typhoid or any other thing because they do not tells you that your child has infection. They tell you that your child has certain kind of immunity, either early immunity or late immunity. Is still we have a cefixime, which is a drug of choice, which is 18 mg per kg per day for total 14 days if we have a culture proven enteric fever. But if you don't have a culture proven enteric fever, then my suggestion is that we can consider the other possibilities. And in the later couple of slides, I will tell you what to do in this situation. In majority of time, when patients come to me, this is my rule. That's called a 72 hours wait rule. And anytime the patient come to me with a fever, I say we have to wait for 72 hours. The second thing what we do is like we have to ask the parents to document that fever, whatever they feel this is a fever. So giving them a diary and maintain that fever diary is always important. And giving them this kind of understanding that you have to give good amount of paracetamol every 6 hourly. So one of the most important findings we used to see when the child has fever is that hyperemic throat can give you high grade fever, and majority of hyperemic throat are actually viral infection. Enlarged and non-inflamed tonsil with white patches in a clinical setting is just a viral etiology, and because it's a lymphoproliferation and not a bacterial infection. So if there is a no source on examination, a good paracetamol and an alternative febrile medicine is always a rule. Fever documentation and follow-up after 72 hours. These are the three things that you have to do as a physician. Um, Lastly is antibiotic. I would like to talk about that. Anytime you write an antibiotic, you have to think of a pathogen and not the disease. Because you think of a disease, you end up with no management. You think of a pathogen, you know what you are giving. So giving a medicine of a gram-positive coverage to a gram-negative pathogen disease has no value. Giving or combining two same kind of medicine will not helpful for your patient. So anytime you just think of a disease, you know, okay, this child has meningitis. Okay, what is the age of the child? And okay, what are the most common pathogen of this age? And then you prescribe the antibiotic. Um, and also not this disease is the manifestation of the pathogen interference in the human body and not itself itself disease. Um, and in pediatric, I would say that is our rule as well, that if the child come to you, they come with one disease. If the child has an infection, they come with one kind of pathogen that can lead to infection. And if this is not the real scenario, then there are two unlucky things happen. One is your patient's unlucky, and the second is you as a physician is unlucky if you have two different pathogens going on. As I mentioned that if you do not have the culture positivity, you always think of use of antibiotic and what is the maximum use of antibiotic. That's called empirical use of antibiotic. So I suspect someone has enteric fever. So usually what I do is start with a single therapy, which is oral therapy. Think of a pathogen, and once you think of a pathogen, you just decide about what kind of antibiotic you have to take. Send the cultures, and once you send the culture, then this is the high time that you can start the antibiotic. And whenever you start the antibiotic, give an appropriate dose, appropriate duration, and appropriate route. And majority of time the oral route is the best route to give the antibiotic. The maximum duration is 3 to 5 days when you use empiric antibiotic, and if the culture is negative and child is clinically well, you can just stop the antibiotic as soon as possible. Importantly is that before the child leave to your clinic, make sure that you understand the weight of the child and to ensure the correct dosage. The other option is a definitive use of antibiotic, and here the important thing is like you actually need to know what is your pathogen. And once you know your pathogen, so suppose you have a Salmonella typhi and you started the patient on ceftriaxone and amikacin, and you know this is ceftriaxone sensitive Salmonella typhi, you just stop your amikacin, and that's called tailoring of the antibiotic as per the sensitivity and need. Usually single agent bactericidal is always work. Preferred oral therapy, because majority of time the oral and the injectable medicine have the same kind of bioavailability. Suppose ciprofloxacin either giving orally or injectable has the same bioavailability. Metronidazole giving oral or injectable has the same bioavailability. And in terms of like non-infectious one, the paracetamol given injectable or oral has the same bioavailability. So rather than spending more patients money, identify how you can save and how can you save and be a safe and a cost-effective physician. For the duration of therapy, I would say follow the standard guidelines. Suppose you have pneumonia, the treatment of pneumonia is 7 to 10 days. If you have enteric fever and salmonella sensitive cefixime, the duration is 14 days therapy. So exactly know what is the duration of therapy according to the standard guidelines. Again, wait the patient and follow up them on clinically. This is always important. There are certain kind of disease that require combination, and the combination usually given on the basis of the synergistic effect. So suppose a multi-drug resistant pathogen require, which is resistant to 3 or more class of drug, require a synergistic effect combination therapy. You also understand that you have to have a high minimal inhibitory concentration to maintain that. Anytime you make a combination, just think of certain things. Number one, both bacterial combination can be used, oral and injectable combination can be used. So suppose sometime in a E. coli UTI, you give both uh, amikacin and cefixime just to ensure that you cover both kind of coverage in a bad UTI like pyelonephritis. And you choose the antibiotic as per sensitivity, ensure there are different class and mode of actions are different. So suppose giving a medicine of amoxicillin and meropenem to a child, both actually act on the beta lactams cell wall. So giving the same medicine, giving a medicine that act on same receptor is not appropriate. So amoxiclave or can be a drug. Amoxicillin and cloxacillin combination drug is not a value of these time. The reason behind the amoxicillin and cloxacillin work the same on the same receptor, and they compete each other, they inhibit their work together. Lastly but not least is your safety labs. Know the adverse effects of the drug prescribed. Ensure that you communicate the patient. And some adverse events are dangerous, particularly Stevens-Johnson syndrome and others. So we must make sure that you know your patient's drug, and you also tell them the serious adverse when that can potentially or possibly happen to the last child. So in summary, fever is a sign and a manifestation, and history examination is the key. Think of simple thing first, like viral infection, simple drug, one drug. Think of pathogen and not the disease. And remember, a 72-hour rule actually protect you and save you to prescribe a lot of medicine and protect the child for different kind of adverse event this could happen to this child. Lastly but not least, that you are the advocate of the patient and not the parent or any other thing. So make sure that you understand what is the best for your patient who's come to you for a clinical checkup. I thank you all for listening me, and I'm happy to answer if we have more questions. Over
Gee,
to you.
thank you,
Thank you.
Dr. Ali. That was quite insightful, actually. I think all the participants have really gotten a lot of information from this. We do have a few questions, and I'll just give you those questions and until the time ends. So, the first question that we have is, when should we not follow the 72-hour wait rule for children with fever?
Yeah. So remember, like, so suppose you have a child who develop those dangerous signs, like racing heart, like hypoxia, like seizures, like low GCS. So you do not need to follow the 72-hour rules. Poor capillary refill, you do not need to follow that rule. Persistent or just a CBC that shows a severe thrombocytopenia, just ignore the 72-hour rule and just send the patient on to us to a high level facility. So the answer is need to understand the bad disease or the bad signs, and these are the bad signs I mentioned for you.
Right.
Over.
Thank you. There's another one. This one is about how should we manage fever in children with conditions like dehydration or metabolic issues?
Yeah. So remember, like if you have a reason if you have a cause or a reason for a fever, treat the cause or a reason, and then you have the answer. So suppose dehydration, fever in a dehydrated child, the best is hydrate the child. The hydration can help you in reducing the temperature down. And lastly but not least, in a metabolic acidosis, the metabolic acidosis happen because of a reason. So correct the metabolic acidosis and you have the answer.
Right. Another question is that what are the main signs that the fever in a child could be very serious?
So fever in a child could be very serious. So suppose suppose I'm talking about a newborn or who's cranky, who's not feeding well, or a newborn who's just drowsy, or a newborn who's just persistently vomiting. These are the signs that for a newborn, a febrile child, that you are really concerned. For an infant, I would say crying episode, persistent crying episodes, and a febrile child, and not calm down on conventional methods or all those inconsolable cry. This is again a sign. A seizing child, or a persistently seizing child, or a child who has persistently high grade fever for a longer period of time. So usually the viral fever happen for 1 hour or 2 hours and then this resolve. But a fever episode of 5 or 6 hours of high grade fever, that is again, these are the danger signs, and one should always consider about uh, this next level care.
Right. There was a question regarding antibiotics as well. What should antibiotics, when should antibiotics be used to treat a child with a fever?
So the answer is that you need to be sure and assertive about the use of antibiotics. So against your 72-hour rules pass and your child is not happy, your child is getting sicker and sicker. So best to investigate your child, get some lab tests done, and start the antibiotic. As I mentioned, there are two types of antibiotic way. One is empiric way and the other one is definite way. So in these situations, you start with empiric antibiotic. You send up the MPICT. You think that is why child has malaria. So saying MPICT, you think the child has enteric fever, send a blood culture. You feel the child has pneumonia, get a chest x-ray done and start the antibiotic, but make sure that you have a follow-up in 3 to 5 days to understand that this child really need just empiric antibiotic therapy or a prolonged or a definitive course of antibiotic. And your investigations can guide you along with the clinical history and examinations.
Right. There's a very, I think, interesting question. Somebody has said, "K, is there a easy way to tell if the fever is caused by a virus or a bacteria?"
Yeah, that's very easy, right? So what I used to say to my parents, to the child's parent is like, one, you give 4 times paracetamol. That's rule number one. The rule number two is if your child is remain happy in between febrile episodes, up and about, eating, drinking, talking, and moving around, it means the child has a viral infection. And lastly but not least, look around the other children or other people who have the same kind of illnesses in your like in the house or nearby house, just to make sure that the child probably get the virus somewhere else. So these are the small things, and again, there's no easy answer, but these are the small answers you have. Over.
Right. Dr. Ali, there are just two more questions that I would ask you. There was one that's actually quite interesting, and I think you even spoke about this. How can parents be educated about the proper management of fever at home?
So the proper education of the parents require that a clock of good paracetamol and checking of the fever. So remember, like my rule of thumb is like remember a clock of 6 to 12 and 6 to 12. 6 morning, 12 noon, 6 evening, 12 midnight. This is the time when you have to give paracetamol for next 3 days. That's called 72 hours rule. The second is like check the temperature. Whenever you feel the child is febrile, do not use your palm or sole to check the temperature. Use the thermometer. Best is you have the digital thermometer that give you this kind of thing. If your patient's if your child's parents are um, illiterate, you don't need to worry about that. Just give them digital thermometer and ask them to whatever they see after this noise, just write on a paper, and you just give them a direction that this is this if this digits appear in this manner, this is all called fever, and if this doesn't, whatever just show up, just right here. So I mean, these are small things, and remember, like parents can be illiterate, but they're not, no, they are uh, not educated. They're very educated. They understand well, and they know their child better, and they always follow the instructions, and they are better and safer for majority of the healthcare facilities we have. So the best, I would say, the best place for taking care of child is the home.
Right. And Dr. Ali, just related to what you were just talking about, which is measuring temperatures as well. The last question that we have received is on this. How do different methods of measuring temperature compare in accuracy?
So remember, like mentioned, one of the one of the study with you that where the digital thermometer checking is measured with mercury temperature, mercury thermometer did not find any change or any difference, and also this head or the strip of this thing, strip checking for the thermometer check on the forehead, and all these temperature monitoring by using eardrum or by using forehead, they are quite sensitive enough in children. So I think the best is choose any of the method and just follow it very regularly. So do not change your methods on multiple occasions. The more you change it, the more you doubt yourself and the more you doubt your thermometer. So best is identify one gadget, use that gadget appropriately, and talk to your physician. They can guide you appropriately.
Right. Thank you, Dr. Ali. This has been amazing. Thank you for all your insights. I feel that all the participants must have gotten a lot of information from this. And once again, thank you for taking your precious time out for us and having this little seminar with us. Thank you so much, Dr. Ali.
Thank you very much for inviting me.
Thank you. For the participants, you can please make sure that you fill your evaluation forms. And after that, you can apply for the certification. Thank you so much. And with that, we'll be ending the session today.